بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. On behalf of the participants, I would like first of all to welcome the participants. And on behalf of the participants, I would like to welcome our speakers today. I start with Professor Mohammed Belghith. He is working in the King Abdulaziz Medical School and Cardiology Center. He's a consultant intervention cardiologist. You are very welcome, Professor Mohammed. Again, I would like to welcome Dr. Khalid Tammam. He is working as a special invasive cardiologist in International Medical Center in Jeddah. And Abdul Maqsood, my brother and friend. He is professor of cardiology at Al-Azhar University, and currently he is working in Jeddah. So I am the guest today. We are four. I am the only one from Cairo with the colleagues from Saudi Arabia. So you are very welcome, and I am your guest today. We have spoken last time or last few weeks with Hani Atiba. We shared the NoReflow and the microcirculation, and we will come to another discussion and another view in the microcirculation. This is one of from one of our regular meetings, cardiology departments, faculties of medicine, Al-Azhar University. We have one for boys and one for girls, faculty of boys, one for girls, one in the Miyat and one in Asyut. So we have four cardiology departments in Al-Azhar University. Coronary artery disease. Why coronary artery disease behavior differs from patient to patient? Coronary artery disease and acute myocardial infarction is a major health problem all over the world. And nobody is immune against myocardial infarction. And infarction now can affect males and females, young and elderly in every possible country. And nobody is immune to develop myocardial infarction. And it is actually a major health problem. We will study and we will persist to study the behavior of coronary artery disease. After myocardial infarction, actually, there are possible 5 pathophysiologies. Normal myocardium perfusion and function. This is a way. Myocardial ischemia with persistent angina, stunned myocardium and myocardial hibernation with left ventricular systolic dysfunction, non-viable infarction, scar tissue, and the complication of the scar. Let us have a look on a few cases just to see the behavior of different patients with myocardial infarction. This is a male patient, 58 years old, diabetic, hypertensive, smoker. He got chest pain, acute coronary syndrome, anterior STEMI was diagnosed, CT segment elevated in all the precordial leads, where widening of the P-terminal force in V1 indicating elevated left ventricular in the diastolic pressure. This patient developed his infarction on the 4th of October, and he came on the 6th of October. So it was 2 days later, coronary angiography was performed, and the LAD was totally occluded with thrombus. The epicardial coronary artery LAD in the epicardium was nicely opened, and we can see filling of the dye with the anterior, with the LAD. Unfortunately, this patient persists to have progressive shortness of breath and heart failure, and there are current admissions to CCU with heart failure. This is not his picture. Echocardiography was done. It showed markedly dilated left ventricle, scar septum, thinned out septum, loss of systolic thickening, and the dilated left ventricle, mitral regurg, and the dilated left atrium. So this patient was anterior MI. His LAD was opened late, and he developed the ischemic cardiomyopathy and persistence in heart failure. Ahmed was 37 years old man. He is diabetic and smoker. He was 37 when he developed the anterior myocardial infarction, and coronary angiography was done. It showed a huge thrombus occluding the LAD here, and it could be opened, and the LAD could be opened with this huge thrombus burden of IMAD. 3 years later, in 2016, Ahmad presented with hemiplegia. So the main problem was hemiplegia. Unfortunately, he continues to smoke and who continues to be addicted as he is. When we repeated his ECG, this was 3 years after his myocardial infarction, there was persistently elevated ACT segment elevation in the anterior leads here. When we performed coronary angiography, there was a huge left ventricular aneurysm, spontaneous echo contrast, and thrombus formation, and distal embolization and hemiplegia. This is not his, but hemiplegia is a possible complication of myocardial aneurysm, and the other complications include ventricular tachycardia, heart failure, left ventricular thrombus formation, and embolization, and persistent angina, and recurrent angina, rupture, and the other possible complications. The third patient, Mr. Talat, is 64 years old. He is not diabetic, but hypertensive and smoker. He got anterior ischemia and ST segment elevation in 16. His LAD was totally occluded here, and it could be opened. We can see it opened here, and there is a good perfusion of the LAD. Mr. Talat is probably came in the proper time, and his echo showed hypokinesia of the apex, anterior wall, and septum, and he actually has a near normal life and functional capacity. He did not develop the other complications. So we have 3 different scenarios of anterior myocardial infarction, LAD occlusion, opening the epicardial coronary artery, which is the LAD, and different follow-up and scenarios. What actually we actually see in the cath lab is this vessel, the epicardial coronary arteries. These are what we can see, and we can assess if it is stenosed or not, if it is opened or closed or occluded, and so on. But we never see this very complex myocardial microcirculation, which functions to supply every myocardial cell with its requirements all over the day, regardless of the effort of the myocardium is performing. So the microcirculation, we couldn't see it in the cath lab. We don't know what happened to the microcirculation of the 3 different patients we presented right now. But actually, when we dilate a thrombus-containing lesion, the thrombus migrates distally. It does not occlude only the microcirculation, but it sometimes occludes the collateral circulation that might have developed and supplied, compensates for the chronic total occlusion of this vessel. And actually, the thrombus may occlude both the collateral circulation and the microcirculation, and results in deleterious effect. If the debris is macroscopic and large, it may even occlude some of the epicardial branches of the coronary arteries. So what happens during mechanical opening of a thrombus-containing lesion is embolization of atherothrombotic debris induces microvascular dysfunction and diminishes myocardial perfusion. And this is an example of a patient with LAD disease and the thrombus here. He had anterior myocardial infarction, and the diagonal was involved in the disease here. The wire was placed, and another wire was placed in the diagonal. The balloon was inflated to open this vessel. It was fairly able, but when the stent was placed, there was TIMI 0 to 1 flow, and actually even the epicardial coronary artery, it decreases the myocardial flow. So an acute myocardial infarction containing a thrombus, mechanical reperfusion by balloons, stents, and whatever we do in the cath lab may result in distal embolization of atherothrombotic material, This results in low myocardial, can be assessed by low blush grade. Delayed ST segmental resolution results in bigger infarct size, heart failure, and increasing mortality occurs in such patients. Can we help all these patients? Yes, we can help them by pharmacological and or mechanical measures to decrease the effect of the thrombus on the microcirculation and the integrity of the microcirculation, including apixaban injection, vasodilators, nitroprusside, verapamil, adenosine, inhibitors of various metabolic pathways, glucuronidine, local injection of fibrinolytic agents, and mechanical by manual thrombus aspiration or mechanical thrombectomy or distal protection devices, guard wire, filter wire, angioguard, and others. Mesh covered stent that entraps the thrombus between the mesh and the vessel wall and prevents protrusion of the thrombus from the struts of the vessel has been tried. Self-expanding stents have been tried, but none of these pharmacological or mechanical measures has proven to be very effective in every patient. And the operator should try to use one or more of these methods just to preserve the integrity of the myocardial microcirculation. So till now, we don't know exactly which way the left ventricular remodeling will follow after myocardial infarction and what is the fate of myocardial infarction in a particular patient. And there are a lot of questions we need to answer right now. Why these patients behave differently? Probably because the myocardial microcirculation problem. Probably because collateral vessels are occluded. There are causes for this. Those who came late, those with larger thrombus burden, and so on. Is there a rule for the thrombus burden? Definitely yes. The larger the thrombus, the more we lose from the microcirculation, myocardial microcirculation, and we lose. Is it microcirculation obstruction? Definitely it has a major role. Can we predict the behavior of the disease in a particular patient? We can. Those who is delayed resolution segment with resistant angina, those who have myocardial blush grade 0 or minimal, so we can predict, but this is not definitely diagnostic. Can we modify the microcirculation injury that occurs during the cath lab? Yes, we can use pharmacological and or mechanical measures as we mentioned, but none of these mechanical or pharmacological measures are 100% successful in every patient. And the operator has to play with what he has from these measures to decrease the insult to the microcirculation. Can we measure it? Can we measure how much injury has occurred to the microcirculation? And thus we can predict the behavior and we can predict what will be going on in the future. This is a question which Abdul Masood will answer right now. Thank you. تفضل يا دكتور محمد. دكتور محمد بالغيث. Hello.
Thank you very much, Professor Sameh. Thank you. I think it's the time for our next speaker, Dr. or Professor Abdul Maqsood. He is a University of Al-Azhar professor and working now as interventional cardiologist. He's the director, I think, of cardiac cath lab and cardiac center in Irfan and Bagadu and Jeddah. And he will talk to us about deep dive into coronary microvascularization or microvascular dysfunction. Dr. Abdul Maqsood.
Assalamu alaikum. Mr. Chairman, co-chairman, my colleague, it's my real pleasure to be with you today to talk about the chronic coronary microvascular dysfunction. You can see my slides now? Dr. Mohammed,
Not
Dr.
yet.
Sameh, you can see my slide?
Share a screen. No, not yet. Try to share your screen again. Share a screen.
Okay.
The green button
So I
down.
will, okay, share screen.
I think Dr. Sameh should close their screen. Dr. Sameh, you should close your screen. Dr. Sameh,
I think now it's okay.
Yes, yes.
Yes, now it's okay.
Thank you.
Okay, so again, it's my real pleasure to be with you today to discuss one of the most important topic in cardiology, the chronic microvascular dysfunction. Really, it's a real problem, and we can see in our daily practice all this clinical scenario in different group of patients, like chronic stable angina patient, the patient with exercise test, post-PCI, and post-MI patient. As we are intervention cardiologists, when we are performing coronary angiography, our main interest to look for the epicardial vessel and to see this kind of lesion. This is male patient, and his age around 55 years old, and he came to my clinic by typical anginal pain, and I sent him to do CT angiography. And before CT angiography, he came to me, I have severe resting pain. So I admit him, I sent him to the coronary care unit, and I did for him this coronary angiography. And you can appreciate the bifurcation lesion type 0, 1, 0. So it's so easy for all of us to proceed for BCI, and it was provisional stenting, one stent in the main artery LAD, crossing the diagonal branch without any compromisation of the flow to the diagonal branch, and followed by POT to do optimization of the stent against the wall. And the procedure was successful 100%. But most of us, we forgot the microvasculatures. And as you see here, coronary angiography does not show all the picture. We are seeing only the epicardial vessels. So the microvasculatures represent 95% of the coronary circulation, and the epicardial vessels represent only 5%. Despite the microvasculature represent 95%, and we cannot see during angiography, it is responsible for angina, responsible for ischemia, responsible for morbidity and even mortality. And we will see in the coming slide how this microvascular dysfunction can lead to major adverse cardiac event, including mortality. So the definition of coronary microvascular dysfunction, there is four diagnostic criteria. Typical anginal pain, exercise modalities showed ischemia, and we did angiography, and there is no any evidence of significant obstructive lesion or normal coronary. So patient with angina, ischemia on stress modality, and no significant obstructive epicardial coronary artery disease. And you did physiological assessment for this patient in the cath lab, like IMR, CFR, and you found the CFR very low and IMR very high. So this is the classic diagnostic criteria for coronary microvascular dysfunction. Typical anginal pain, stress modality showed evidence of ischemia, absence of obstructive coronary artery disease, and confirmed by high IMR, which is index of myocardial resistance, and low CFR, which is coronary flow reserve. Classification of microvascular dysfunction, there is 4 types. Type 1, which is isolated cardiovascular dysfunction, and the type 2 coronary microvascular dysfunction with myocardial disease, coronary microvascular dysfunction with coronary artery disease, or iatrogenic coronary microvascular dysfunction. Type 1, which is isolated, we can see in a smoker, dyslipidemic, hypertensive, diabetic, microvascular angina, and syndrome X. CMD with myocardial disease, like in patient with hypertrophic cardiomyopathy, dilated cardiomyopathy, and infiltrative cardiomyopathy. CMD with coronary artery disease, as Dr. Sameh mentioned, the common case, which is acute myocardial infarction due to distal embolization by thrombus or atherosclerotic debris in the microvascular tree. Type 4, which is iatrogenic CMD, and we can see, all of us, we can see all this scenario post-BCI in a stable patient, and after complete resolution of the stenotic lesion without any angiographic evidence of lesion in all coronary, the patient is still having persistent anginal pain after the procedure. And this is due to distal embolization of atherosclerotic debris in the microvasculatures. Why microvascular dysfunction is important? Because up to 40% of patients continue to have angina despite successful coronary revascularization. I am sure all of us confronted this group of patients. After BCI, they are coming to us by anginal pain. Most often, the majority of these patients, they have microvascular dysfunction. About 20% of patients with a chest pain are found to have no angiographic apparent coronary artery disease. And this is very common scenario. Patient with typical anginal pain, we send this patient to our colleague in non-invasive lab. They did any stress modality and they came positive. And you will send this patient to coronary angiography. And unfortunately, we found the epicardial vessels nearly normal. So maybe more than 50% of this group of patients, they have microvascular dysfunction. Is microvascular dysfunction predict adverse outcome in variety of clinical setting? Yes, microvascular dysfunction predict adverse outcome in a variety of clinical setting, and I will show you in the coming few slides. This is just to remind all of our attendees and to remind us the coronary physiological indices in the cath lab. Regularly, we are using, if we are focusing on the epicardial vessels, so we are doing the hyperemic FFR or non-hyperemic indices like IFR or RFFR. So if we are concentrating and focusing in the epicardial lesion, we will do FFR, which is hyperemic, and non-hyperemic IFR or RFR. But if we are concentrating about the microvasculatures, so there is two indices only. IMR, which is index of myocardial resistance, and we can measure it by thermodilution technique by the same pressure wire. And I will show you how to measure the IMR using the regular wire we are using from Abbott, which is Radial wire, and a special wire, which is Radi-X, because it's including a pressure sensor and temperature sensor. The other modality, which HMR, and this is well studied by Doppler wire, but we will concentrate today about the IMR, FFR, and CFR. So CFR, it's indices which interrogate the entire coronary circulation, epicardial and microvasculature. So it's not specific for microvasculatures because it will be affected by the hypotension, tachycardia, bradycardia, or dobutamine. So the definition of FR, it's estimate the fraction of myocardial flow impairment attributable to the epicardial stenosis. So if you want to assess the epicardial vessel, either focal or diffuse disease, you have to use hyperemic FFR. To remember the normal value, normal FFR should be 0.8 or more. Ischemic definitely less than 0.8. IMR, which is index of myocardial resistance, it's estimate the fraction of myocardial flow impairment attributable to the microcirculation. So it's highly specific for microcirculation. And normal value of IMR, don't forget this number, 25. Blue 25 normal, above 25 abnormal, and high IMR, which indicate microvascular dysfunction. Coronary flow reserve, which is CFR, reflect impairment of myocardial flow reserve caused by epicardial and microvasculature. So it's for interrogation of the entire coronary circulation. To remember, the value of CFR should be more than 2. If the CFR less than 2, this is abnormal CFR. So the CFR, it's not specific for microvasculature because no clear defined value, mainly if young or old. So in young, if less than 3 normal, if old, less than 2 normal. And definitely it is affected by resting hemodynamics. It is affected by tachycardia, affected by hypotension, and affected by vasopressor or inotropics. And I will show you now how it's affected in different studies. This is very important coronary reactivity testing, adenosine. If you want to do FFR, so you have to do to give adenosine. And to remember the dose of adenosine, the dose intracoronary bolus should be 100 microgram bolus. And if you will give it intravenous, I think nobody giving intravenous now, you have to give 140 microgram per kg per minute. So most of us, we are using the adenosine, 100 microgram intravenous bolus for assessment of FFR and index of myocardial resistance, which is IMR. So measuring microvascular resistance using IMR has potential advantage available in the cath lab in the pressure wire, specific for microvasculature, quantitative and reproducible, and predictive of outcome. And I will show you the different clinical scenario. This is how to estimate the IMR in the cath lab. You can appreciate here on the left side, the guiding caster and the pressure wire coming from the guiding caster. And this is unique pressure wire because there is sensor for the pressure and there is 2 sensor for temperature. The shaft of the wire act as proximal thermistor, and the distal end of the wire showed the distal thermistor. And the proximal thermistor estimate the time of injection of room temperature saline in the coronary artery. And the distal thermistor, it will estimate the thermodilution curve. And as you know, the flow of the cold or normal temperature saline in the coronary artery, it will reflect the coronary flow. And this is clear in this curve. So how to calculate IMR? IMR against distal coronary pressure times mean transit time of normal saline at maximum hyperemia. So by this, you can get the IMR. And this is how to be reformed in the cath lab. This is manifold. This is syringe with 3 cc normal saline or cold saline. And you will inject the saline, you will get this curve. And the time of passage of the normal saline represent the coronary flow. We will inject the saline 3 times, and you will take the average time, I mean mean transit time of saline in the coronary artery, multiplied by distal pressure by the pressure wire, it will give you the IMR. And I will show you different clinical scenarios. So this is the practical measurement of INR, distal coronary pressure in the green here on the right side of the screen, which is 89, multiplied by mean transit time, which is 0.37. So if you multiply 0.37 against times diastolic pressure, it will give you IMR of 33. Remember, the normal IMR 25, here 33. So this patient have microvascular dysfunction as detected by detection of IMR. So the normal value, don't forget, normal value of IMR less than 25. If 25 or more, so it will be good indices for microvascular dysfunction. And this well studied in multiple 3 trials, control patient with absolutely normal coronary artery. So the normal value less than 0.25, the index of myocardial resistance, if showed abnormality, should be more than 25. If the IMR reproducible, yes, because as I remembered, this is the 3 indices, CFR, IMR, FFR. If you will do tachycardia and you will measure after pacing by heart rate 110, in this group of patient, 100% the FFR and IMR fixed, but the CFR changeable. Here also by using hypotension by nitroprusside, IMR fixed, FR fixed, and CFR changeable. And this is by the effect of dobutamine, CFR changed, IMR fixed, and FFR fixed. When should we assess the coronary microvasculature? And this is very important in patient with chronic coronary syndrome and normal coronary arteries, like patient we did complaining from angina, ischemia detected by stress modality, and we did angiography, and we found the epicardial vessel, no obstructive lesion. This is the first patient. Actually, this patient is not my patient. It's from Stanford University, and which was presented by Professor William Firon in the CRT meeting. I emailed him and I asked him to take it as educational. Angio was done for this patient, no obstructive angiography. And he is hypertensive, hyperlipidemic, typical anginal pain, and he did exercise echo, and the exercise echo showed anterior wall ischemia. So we have three possibilities: either diffuse coronary artery disease, or high IMR, or false positive test. So we will do IMR for this patient. And here you can see the diastolic pressure against the mean transit time, and you can appreciate the outcome here, the IMR 9. So this is normal IMR, no microvascular dysfunction. So this is epicardial disease? No, because the FFR more than 0.85. So it was false positive test. Another patient, 59 mid, hypertensive, dyslipidemic, typical anginal pain, positive MBI for ischemia and LAD. And you can appreciate here the epicardial vessel, no obstructive lesion. Again, IMR done for this patient, and fortunately enough, the IMR came very high. The mean transit time 0.7 multiplied by the diastolic pressure, and the IMR here was 53. So this is very high IMR, indicating microvascular dysfunction. So it's a positive test, and the cause of angina at the level of microvasculature. Last patient, dobutamine stress echo positive, negative, but the patient is still having typical anginal pain. Angiography done, no significant obstructive lesion, and FFR done, CFR done, and IMR done. In this patient, the IMR normal and the CFR normal, but the abnormality here was FFR, it was 0.5, so significant lesion. What are the explanation of typical pain with low FFR in absence of focal lesion in the coronary artery? Most probably this patient diffuse atherosclerotic coronary artery disease. And you can appreciate the drift of the yellow curve here, gradual increase in the pressure without focal step up in the pressure. This is classic for diffuse atherosclerotic disease. How to confirm? By IVUS. This is intravascular ultrasound, and you can appreciate here significant reduction in the lumen without focal lesion, and there is calcification in the coronary artery. So the final diagnosis of this patient, diffuse atherosclerotic LED lesion, which is responsible for ischemia. This is a Chinese trial, including 150 patients, and all these patients normal coronary, but anginal pain with positive stress modality, and they did analysis why this patient, they have angina. They found 20% have high IMR, which indicate microvascular dysfunction, and 25% of this patient normal, and definitely there is coronary artery spasm indicated by acetylcholine test to induce spasm, and you can appreciate the LED bridge responsible for about 55% of anginal pain. Another trial, Chinese trial, including 313 patients with normal FFR indicating normal epicardial vessel, but low CFR and high IMR, which indicate microvascular dysfunction. Is this predict prognosis? Yes, you can appreciate here is the Kaplan-Meier curve in patient with high IMR and low CFR. There is high significant rate of death and MI and repeat revascularization over 5-year follow-up. Recent study, including a patient in LED, they did FFR, CFR, and IMR in LED, and they found high IMR and associated with acetylcholine positive test. And you can appreciate IMR was the only independent predictor in this trial for this MI and unstable angina. And this is to remind you by the dose of acetylcholine should be intracoronary bolus, and the maximum dose of the acetylcholine 36.4. Don't give the maximum dose first, give small dose, then moderate dose, then high dose. And definitely, if you will give acetylcholine, you have to be really 100% by intracoronary nitroglycerin to relieve the induced dyspnea by acetylcholine. And the dose of the vasodilator intracoronary nitroglycerin should be 200 microgram. What we will do for this patient, we know already there is angina related to microvascular dysfunction. This is from CORE-MICA trial, and the stratified the patient angiography treated only, and angiography treated plus estimation of the IMR. The group of patients who did estimation of the IMR showed significant improvement in angina score and significant improvement in quality of life, significant change in diagnosis, diagnostic certainty very high in interventional group, and the misdiagnosis of IMR in the interventional group only 3%, which is highly significant if you compare it with control group. The medication, calcium channel blocker, nitrates, nicorandil, ranolazine, ACE inhibitor, ARBs, and statin therapy. Second group of patient who is a stable patient who is going to do BCI. So we have 100 patients, they are going to do BCI according to the results. And we divided this patient into two groups, group with normal IMR and group with high IMR. And you can appreciate here, the group of patients who did BCI with high IMR associated with peri-procedure IMI, peri-procedure significant elevation of cardiac enzymes. And this is 2-year follow-up at measuring IMR during BCI. It is associated with high rate of MACE, spontaneous MI, this and the spontaneous MI, and this was highly statistical significance. Kaplan-Meier curve showed high IMR associated with higher rate of death and the spontaneous myocardial infarction. Last group of patients, and I need only 5 minutes, I will finish. Immediate after STEMI, as Dr. Sameh mentioned, and Dr. Hani Ateba mentioned 2 weeks, since 2 weeks in his brilliant presentation, and Dr. Sameh, very good data he gave us today. Immediately after BCI, impaired microvasculature predict adverse outcome. And this is one patient also from Stanford University. It's not my patient. Patient anterior STEMI received thrombolytic therapy, transferred to BCI capable center, and you can appreciate the classic LED lesion, which was stented. And actually, this patient immediately after revascularization by lytic and BCI, they found the IMR here 32, and this is very high. Remember, the normal value of IMR 25. Here, the IMR here was 50, not 32. The diastolic pressure 32 times 1.5, so the IMR was 50, so it's very high. So second patient, a same scenario, STEMI, lytic therapy, referred for BCI, and they did stenting for this patient, and they measure the IMR for this patient, and the IMR came normal. So in the first patient, there is persistent chest pain, there is deterioration of left ventricular function, which is 30, and 3 years, 3 months follow-up, echo for the first patient, no improvement in the ejection fraction. Here in this patient with normal IMR after BCI, the cardiac enzymes decreased, the ejection fraction at baseline was accepted, 40 or something, and after 3 months follow-up echocardiography showed good recovery. So the IMR is the only and independent predictor for elevation of cardiac enzymes and for recovery of the myocardium and wall motion if the normal IMR. If abnormal IMR, it will predict bad prognosis and bad outcome. This multi-center study evaluating relationship between IMR and outcome in 253 STEMI patients. And you can appreciate here, the group of patients with normal IMR have higher survival rate. but the group of patients who has high IMR, they have higher mortality rate. So IMR, it's a predictor of recovery of myocardial function, predictor of deterioration also of high IMR if you compare it with another parameter. What we will do for this patient, this is very nice trial, as Dr. Sameh mentioned in his talk. They will do now restore MI study scheme. This is new trial assigned for patient only with high IMR, and they will divide this patient post-STEMI with high IMR into two groups, group placebo and the group high IMR, and they will give the high IMR lytic therapy, and they follow the patient for 24 months, and we are waiting the primary endpoint outcome, which is mortality and revascularization for congestive heart failure. Still enrollment going, and we are waiting the results in the coming 2 years, inshallah. So I will conclude my talk today, Mr. Chairman. Patient with chest pain and no obstructive coronary artery disease often have microvascular dysfunction. In more than 50% of this patient, they have microvascular dysfunction. Measuring IMR in a STEMI patient correlate with non-invasive measure, and you know the gold standard non-invasive measure for CFR and coronary flow and IMR, which is PET scan. And definitely high IMR in patient with STEMI predict mortality. So the next frontier will be determine what intervention can improve outcome in patient with acute and chronic microvascular dysfunction. This slide, please keep it with you. This is the coronary reactivity testing in the cath lab for the adenosine, for the acetylcholine. Definitely we are hearing about acetylcholine induced spasm for patient with Brenz-metal angina, but unfortunately we are not using it. But this is a protocol, international protocol for adenosine and the international protocol for acetylcholine. And during acetylcholine test, don't forget to have ready intracoronary nitroglycerin to relieve the spasm induced by acetylcholine. Thank you so much for your attention.
Thank you, Dr. Abdul Maqsood. Dr. Sameh, do you want to introduce the second speaker?
Good evening, everybody. Would you please leave screen Abdul Maqsood? Leave screen Abdul Maqsood. Our next speaker is our friend, our colleague, Professor Khalid Tammam. He is working in the medical center as intervention cardiologist. And actually, Khalid has impressed us several times by the CTO cases he is performing, and he is a pioneer in this aspect. So we are looking forward to hearing Khalid Tammam talking about the basics of CTO. This is a learning lecture to those who are aiming at starting their CTO program for chronic total occlusion patients. Khalid.
Thank you, Professor Sameh, for this nice introduction. I'm very happy to be with you here in this very intelligent course. Also, it's changing the pathway from acute to chronic now. It's will be difficult after Abdul Maqsood with very intelligent and very nice talks, and for your talks as well, Professor Sameh. I would like to not make it long, but I would like to, it's very nice to start the basic. So I will share my screen. Can you see my screen now?
Yes.
Yes, we can see well.
Okay, so it's very nice to always to talk about the basic, because always we are going, if a CTO is very complex, so we're going always to complex. And when we don't know the basic for the CTO, we face, when we start the complex, that we are not well prepared. So at that time, the complication starts. So we have to know everything, the basic from start. So first, when we, to think about CTO program or CTO in general, we have to know where we are now, choosing of PCI, CTO approach, CTO toolkits, what we have to have it in our cath labs and clinical practice case presentation as usual. So where we are now. So how to start with CTO? We have to know the pathophysiology of CTO at its is. So the CTO definitions, that's as we know, that's Dr. Sameh has been talking now about the patient with acute MI, which has a tragic thrombus and sometimes occlusion artery. This is called function CTO or acute occlusion at the same. And if it's for several weeks, it's just occlusion with a function occlusion less than 3 months. And when we have a 3 months, it's a complete occlusion, and this is mean chronic total occlusion. Usually when we look for the vessel inside, we see that there is a very tough lesion in the proximal cap and the distal cap. The distal cap always a soft, still the soft material is inside. That's like a thrombus, some lipids, and this softer core. It's a distal core of the CTO. According, we don't know it's a long or short. And the proximal cap, it's became fibrotic by time, and then by time came calcified and resistant tissues. This is a proximal part of the CTO. And of course, nowadays, with using of the statins, high dose of statins during the MI, this calcification is progress. And this we all observe that all the patient became very calcified lesion in these days. That's maybe because of the statins. So if you see here, this is the non-CTO lesions, and here is CTO lesions. This is by angiographic. And if we go to histopathology of this patient, that we see that or a small, a fresh lesion, we can see the soft plaques, 50% of cholesterol, macrophages, and loss of fibrous tissues. And when it's became longer by times, is over 3 months, it start to have a hard plaque, fibrocalcific, and the collagen is increasing. So, and this is very important. So patient with CTO represented with challenges demographically. When we see the most common patients undergoing with angiographically, in general, we have 18% of the patient with coronary artery disease, they have CTO, and the 54% of these patients with CABG, they have a CTO, and 10% of STEMI coming to you in your cath labs have CTO. So this it's a very huge number. So we have to know how to deal with CTO in the future. So in CTO patients, majority of the CTO patients, they are almost diabetic. They have a peripheral vascular disease, previous stroke or heart failure, MR, LV dysfunction. So if we can, again, to see PCI used to treat a small population of CTO, but has higher success rate. So this kind of the population, PCI with CTO, 30% of the artery has been receiving PCI. Still, 30% of these patients receiving a PCI, and 45% receiving medical treatment, and 25% as going to coverage. This all data, but now it's increasing because the CTO operator and the experience is increasing. The tools has been developed very highly, and it became the success rate and the complication rate is decreased. So then success rate increased. So this number has been increasing. So again, when we think to do CTO, we have to think about the benefit of the patients. Until now, all the data we have that the CTO improving the quality of life. This is not taking care of the, this is not, we don't have enough data to show that is increasing the survival, except the patient with STEMI and CTO lesions. That small data shows that's improving the mortality when the patient has CTO with a primary or without primary. So those with the CTO and have a primary PCI or acute myocardial infarction, they have more mortality than the people without CTO. But in general, the CTO improving the quality of life, and which is enough to treat the CTO. So if the patient have quality of life very poor, is 60, 50 years old, and still have chest pain, they have a heart failure symptoms, and he has only CTO lesion who's doing for him all this, so to relieve these symptoms, I think this is a noble for him. So improving the anginal symptoms, which is documented, normalize the LV function sometimes, improving the LV dysfunction, yes. Avoid the cabbage sometimes when the cabbage is very difficult and we have not LAD lesions, so CTO to circumflex or RC, it's also reducing the cardiac mortality, which is still question mark, except the STEMI patients. Again, the challenge is always when we have the CTO is the prognosis, benefit versus medical treatment. So prognosis of this open this artery, success rate, it's still question mark. Operator experience is have a very long learning curve and difficult crossing and wiring and complications in this field. The complication is higher, including the perforation, contrast nephropathy, radiations, injuries, and sometimes closing of microcirculations, as Dr. Abdul Maqsood mentioned before. This it's became used to change the stable plaques to unstable plaques. When we start CTO, we have to go step by step and to know what to do if we have a CTO case. So technical part, when we have a CTO, you have to assess various indications, which is very important. Then we have to assess the viability. So examination of the patient is very important too before this. So a CTO is not ad hoc procedure. So when we have a CTO, it's not a primary PCI, it's not unstable angina. So all CTO of patient of CTO, they are stable. They have a symptom. So please, we have to take our times to review the patient carefully before to start this huge procedure. So we have to assess first the risk versus benefit of the patients. Then we have to assess the viability, of course. Then we have to very carefully review the angiographic picture of the patients. And this should be done very carefully. The angiography is not a 3-4 view, and that's enough. So you have to have a good angiographic picture to increase your success rate. Then we have to check your axis, what you will start to do. You will do femoral, radial, and this is a radial course, and always radial, it decreases the risk of bleeding in those patients. And you know, this procedure is very long, 3 hours, 4 hours. So patient need to be mobilized after you finish CTO. So bilateral radial always in obese patient is options. And now we have a cylinders sheath, so you can use a 5 French even, except if you use a 8 French, you have to go femoral. Based on the operations, the anatomy, then type of the procedure, antegrade, retrograde, basoflasion characteristic, performing of PCI, you have to do the CTO in very equipped labs. So before to start CTO, please have all your toolbox in your cath labs. So don't start to do CTO without having a microcaster, a good guide wires, all your balloons, or your stent, and the toolbox for complication. You have to have it in your cath labs, including the graft stent, coils, and you pericardiocentesis kits, cardiac surgery backup. It's sometimes if you have a very complex cases. Dr. Sameh asked me today to start only with antegrade. Maybe in the future we start with retrograde. I was guiding EDR, and this I think it should be in the future. So we don't start to have a direct retrograde approach without have a good antegrade approach skills. Then challenges situations always should be at the end. You have to take care all the time about your radiation to the patient, because sometimes we are sitting, and this was before, we're sitting 3 hours, 4 hours, and forget that there's one projections all the time, LAO, REO all the times, and then patient finish with a big burden of radiation in his back and start to have a skin cancer in the future. So you open CTO with a stable patient and you convert the patient to the cancer. Again, tamponade is very important, and switch to cabbage and the other I mentioned before. So again, that's very important to know the anatomy before to start. Calcification is very important. Sometimes we need to have a coronary CT to know the root. How is the long lesions, short lesions, calcifications? This is very important to have sometimes. But again, make sure that a lot of radiation given to this patient, including scintigraphy, a CT scan, and a very long procedure of angio. So CTO should not be, again, you have to plan, and it's very important. And this, when we start the learning curve, we do the CTO at the end of the list. You have, for example, in Azhar University, because we're talking in Azhar, they have a very long list, and they start the CTO the late, when the people, they are exhausted, which is very bad. You have to do it at the morning, and you have to plan at least 2 hours in your cath labs. So this is very important issue, to dedicate 1 cath labs for CTO without any somebody pushing you. We have patient waiting outside, please be in hurry, and this kind of stuff. So you have to dedicate 1 cath labs for you. Don't make it at late, because you need to have a fresh power as operators. Also, your teams should be alert, because sometimes you work with a bilateral injection and your colleague is tired, your nurse is tired, and then you start to inject a thrombus in donor artery and patient die. So very important to know the steps. Complication, it's very important to be planned for complication. Contrast is very important to know the contrast. You have to calculate for all patients the GFR, and you get a GFR time 4, you get the contrast, the maximum contrast you can get. Radiation, you don't reach more than 10 gray per time. That's very important, you know it before start. And when you start the CTO, you have to know these classifications of CTO. Classification of CTO, this is important to know that when we have a 0, 1, or 2, or 3 with Rentrop calcifications, this is CTO. And also you have to know your success rate with GCTO scores. The GCTO scores is in the internet. You can download it, and this can give you the success rate you will have, or the difficulty level of difficulty of CTO. That's if you have a 0, it means easy. 1, it means difficult. 2, very difficult. 3, very, very difficult. And then 4, very, very difficult. So this, it's you have to have it also to know your difficulty of the patients. Again, here you have to make your setup very good. Setup, good backup. As you see here, you have to have always bilateral injections, and try to manage from beginning. If you will use IVAS guiding, we recommend you to have 8 French or 7 French. If you have 7 French, you have to choose your microcatheter. You have to know your microcatheter, what microcatheter you will use before. Because some microcatheter can go with 6 French, but they cannot have a trapping to take your microcatheter out with 6 French live. If you can go with a bulky microcatheter like Crochet, or you will go with a more than 3 French, you have to have a 7 French. Otherwise, when you put balloon inside this microcatheter, you cannot pull it out. So 7 French is a good for this kind of. If you use a fine cross need with 6 French is okay, but always you make sure that you will not need something more. Double injection or dual injections is a must for CTO, because never believe you are a true human or not with a single injection, especially if it's long CTO. So you have to have a double human, double injection, left and right, and you can use radial, femoral, according to what you can do or what it's easy for you. For me, I'm using radial femoral all the time with 7th French, or femoral when I'm with in some cath labs, they are not equipped good for radial. And radial in obese patient is the best. So optimization of visualization of the CTO vessel is very important. The length of the CTO, it can give you the good indication for success rates of its short CTO segment. Of course, the success rate will be much longer, much higher than the longer CTO. Calcification, bifurcations is very important also to know that you will have a dissection re-entry or not in the bifurcation. Visual torsosity, and this can be assessed with a CT before, that can give you all this information. Again, the best radiographer or angiographic picture, of course, we are all used to have a 15 millisecond or 15 per second frame per second, and this as usual. But in longer procedure, try to have a 7.5, which is decrease your radiation dose, and very important to take care of your radiation dose and radiation exposure to do your artery, to do your CTO. Again, the collaterals is very important to preserve your collaterals if you will use a CTO retrograde in the future. Collateral damage is very common. And we see by Myocardial Plaques in the progress CTO registry that the complication rate in retrograde, because unexperienced operators or operator not use the CTO retrograde, it's increasing the mortality. As Dr. Abdul Masoud says, that you are close, all the vascular circulations has been done by very good collaterals to do artery maybe is not viable. So try to make sure before to attempt that you are mastering the retrograde to not close these collaterals. Again, this we have mentioned. So here's the radial or femoral, and this was the advantage and disadvantage. Of course, the femoral advantage, because this is a radial course. So I put this slide. So femoral is easier access. Big one, we can use the 8 French. We can put a bilateral cheese. We can use a pacemaker. But again, this we have to pay attention with the bleeding, with the patient prolonged. Again, this is very important. So again, here, if we think about CTO, we have 3 techniques to do CTO: antegrade, retrograde, dissection re-entry techniques. So we talked about the antegrade first. So antegrade is a very important one, and the basic one we have to know all. And believe me, now with the all new technology we have, the success rate of antegrade is more than 95%. So we all know that the success rate improved after we have a new series of Gaia wires, of Asahi wires, and Boston has been also the new wires. They have Hornet wire, and all this new wire and new technology has been appear, and the operators skills also improved. So we can have achieved success rate of wire escalations antegrade more than 95%, which is a great number. That's before CTO, before was not that one. So here, what we need, it's very important that we have ambiguous cap, proximal cap, poor distal target. We have to know that's yes or not. If it no, that we have not ambiguous cap, so the cap, the proximal cap, it can be tapering or even ambiguous but short, and distal is okay. So antegrade, it's good also. We use if the lesion length is 20 millimeter or less, so antegrade wiring will increasing, will be successful. If it's no, so you may need to have a antegrade dissection re-entry if you have a good landing zone and with no bifurcation and no tortuosity. So they have a character. They have we have to put indication for this one, and we will talk it later. If it's a very long, ambiguous cap, very poor target, and failed trials 2 times in good operator before, or failed the trials in with your hand before, so you have to go direct retrograde, because by retrograde you will increase the success rate. And again, retrograde, or you can have a direct lucky to puncture the soft plaque from distally, and you go from true lumen to true lumen by retrograde, or you will need to have a reverse cart techniques, or that's mean the cart mean antigrade retrograde dissection reentry techniques. That's mean cart, which has been described by Dr. Kato in Japan. So, and this means that you will go from true lumen to false lumen, then true lumen again by retrograde, and then you do externalization. And this, I think we have to have a special presentation for dissection reentry and retrograde. So I will pass. Why CTO is difficult? Because again, we don't know the entry, we don't know the root, we don't know the vessel diameter, and this should be answering before. But was and if you see here, that's very bad artery, very long CTO RCA distally from proximal to distal. We don't know where is our root, and here's the questions: where is the root? And this is the correct route. We have to go by this one, and this will be sometimes difficult. So, or we go this one, or we go this one. So this is very important. This direction is these are correct, and also correct. So this one is correct. The other one is not correct. So here, when we have this kind of lesions, we have to know how to enter, what's the root, and what's the diameter. So the entry point always is intima or perforate. So if we don't go by intima, so we go by dissection and end up by perforate if you are not very careful. And here, so you have to know what tools you will use to do this kind of lesions. So again, you have to know the anatomy very well. You have to study the angio very well. You have to know the technicality you will use very well, and you have to choose your device. This is a very important 3 points you have to put in your mind before to start. If you have this one in your mind, you will decrease your complications. So here again, the wire you have to use, it should be has all this kind of technology in your wires, like coil wires, have a hydrophilic coatings. Sometimes you need a stiff wire to have a puncture the artery. So every lesions, they have to start with the other wires according to what we need. I'm not talking technically about the wire this in this particular presentation, but I will tell you, if we have, for example, instant occlusion for a long time, you cannot go with software like Felder XTR or like Pilot 50 or Pilot 150. We have to have a puncture with a stiff wire like Confianza Pro 12, Gaia Third, Hornet wires. Then we de-escalate again. But when we have like a short segment, you can find the micro circulations. So then we can start with a Felder XTR or Pilot 50. So according to what hard the lesions you will choose your wires. And please, now I'm using only 3 to 4 wires to do the CTO, not many wires like before. So again, this all for retrograde. I will not talking about. Let me just present for you one very good anti. So let me present this one first. So again, you have to take care all the time to reduce your fluoroscopy time, not making a lot of fluoro. You have not a lot of cine. You can install your fluoro to decrease your frame rate, and please make sure that you are not exceeding and this is the limitation of the CTO all the time. We have a two limitation: contrast media, patient discomfort first, if the patient is tired, or if the patient is tired, you have to stop the procedure. Regardless, if you are not advanced very well and patient start to be tired, start to be complicated, you start to have a hypotension, something wrong, you have to stop. And bring the patient when it's in good shape. So this is nothing to do with your techniques. Second, the contrast media. If you exceed the contrast media GFR multiplied by 4, you have to stop, because otherwise you will open CTO and end the patient with dialysis. Third thing, you have to take care about your radiation dose. If you go with 4 or 10 gray per minute, so it's mean that you have exceeding 4,000, 5,000. That's very much milligray. So you have to stop and bring the patient another, and try all the time to change your projection, because if you keep one projection, that's mean it's that's a patient will complicate. After 2 months, you will see the skin is gray, is black, gray, and then black, and then ulcerating, and then it start to complication, especially in the back. And patient في مصر يجي يقول لك انا عندي وحمه طلعت لي في ظهري، لكن it's not وحمه، دي skin start to skin pigmentation and may up the skin cancer. So perforation, you have to know the classification of perforation in your head, especially when you start to have a retrograde approach. You have to have, especially the epicardial perforations. Sometimes the perforation is grade 1, but you send the patient to CCU with all this and the patient crash in the middle of the night, and you cannot be careful about the perforation. When you have a patient post-CABG, sometimes you don't have a pericardium and they are bleed somewhere else, the patient complicated, and you will have in trouble. So this is very important, the perforations, and you have to have a step to know that stage 1, stage 2, and stage 3, and then the tamponade. These are very, the internet is very easy to find the earliest perforation. It's also important to CTO attempt by antegrade, you have to switch to retrograde, especially if you have done by good operators. So I will present in 5 minutes. Can you give me allowed, Dr. Muhammad, or I can stop here?
Go ahead.
So it's a gentleman with a 35 years old male patient, diabetic, hypertensive, dyslipidemic, obese. They have a good LV function at that time, with a mortality, with a multi-vessel disease, of course, and he has a Euro score is 1.8, and syntax score is very high, and he has also including CTO, RCA, and this time patient is worker, and they refusing to have any cabbage at that time. So here is his angiographic picture. You can see he has a bifurcation lesion, LAD diagonal. He has also ramus branch subtotal. And he has this kind of CTO. Looks short here, but this very long CTO is not short one. And you can see here, CTO calcific. So he refused a cabbage several times, and he's a worker. He don't want to lose his work. So we did for him an angioplasty to lift anterior descending and ramus branch. When you have this kind of procedure, you don't do it ad hoc. So do left system, and then we assessed a viability by the vitamin stress test to inferior wall. We find that all is viable, which is very important to continue this procedure. Again, here's the RCA. And we did for him a CT scan, and this CT scan is very important, these patients, to see where you will go. If you can read the CT scan, it's very easy for us to read it. You can see that the calcific plaques, here is the calcium, it's not full. So, but here is the circumferential calcium. If we get a cross-section view, we see that here need to have a stiff wire to puncture this calcium. And then you can go, here is a fibrotic plaques. And if we can appreciate here, that's again fibrocalcific plaques here with the calcium, it's heavy in this part. So, and here in the mid segment, which we can see until the cracks, there is a second CTO segment. So there is one CTO segment here, which is already long. And then you can appreciate there is here also the second CTO segment. So the segments is almost as 40 millimeter or more than 40, it's 60 millimeter. So, and it's why we have this kind of CT? Because if you have this kind of CT, you will see that here you can have a penetration wires, which is heavy, like Confianza Pro 12, Hornet, or Gaia Cert, and then you have to de-escalate to the software, like a Felder XTR, and then again you have to escalate again with a Confianza Pro 12, because here the Felder will not go, and then you can de-escalate again. So the 3 steps, this give you a very good indications with what wire you will use by this CT. So I have the level to know that here I will be escalating to very stiff wire, and then I have to go back with the software, because otherwise I will go to subintimal, and then I will go to de-escalate to software, and then de-escalate again to finish. And this is what will happen with us. So here we get with the escalated wire, and then we de-escalate with just a wire here with a Felder XTR goes out, and then we correct the positions. And here we change again with Gaia second. Gaia second here in outside, it's the false lumen. And then we take again the Felder XTR, which going to the true lumen distally. So 4 steps, it can end up your artery, and this after we finish the artery. It's big artery. So I think this is the end. I will end my conclusion. It's very important to know the steps of the CTO, including the indications, and you know your tools, you know your limitations for antegrade. Again, you have to respect your learning curve. Doing in the team, don't doing alone, don't doing in the middle of the night, don't doing in the very busy cath labs. And then when you start, please try to have all your informations, including the multi-slide CT, good angiographic picture to know the vessel route, vessel entry, calcium distribution of the artery. And if you know the key point before to do the PCI, the success rate will improve and it will be increasing. Thank you very much.
Thank you very much, Dr. Khalid. That was very nice lecture. Thank you. I think we got few questions for Dr. Abdul Maqsood. Do you hear me?
Yes, already. Yes, I hear you well.
I have a question here from one of the participants saying, is there any difference in treating the type of CMD, like management? Is it different according to the types?
Yes, it's a very good question. As you know, if you will treat microvascular dysfunction and both this revascularization in a STEMI patient, definitely it will different if you will compare it with patient with chronic stable angina. For example, in patient with STEMI, the most important cause of microvascular dysfunction, distal embolization of microthrombi. So the management strategy here, I think the best way to give intracoronary lytic therapy if there is documented increased IMR, because the majority of this patient, they showed distal embolization by thrombi by the nature of the lesion of STEMI and non-STEMI. So in this group of patients, the majority of microvascular dysfunction secondary to distal embolization. The most important treatment strategy here, the intracoronary TBA to dissolve the emboli. The most important medicine to give it during acute stage here, adenosine, because as all of you know, the adenosine affect only the microvasculature. So you can give intracoronary adenosine, and this is to relieve the expected spasm in patient with acute MI. So in acute situation like STEMI or non-STEMI, the most important approach to give lytic therapy and to give, if you want to give nitroglycerin, it will not work because all of us, we know the nitroglycerin act only in the epicardial vessel. So the adenosine and the TBA is the most important medicine in acute stage. But in patient with chronic stable angina, without enzyme rise, anginal pain, and the positive stress ECG, and they are doing elective procedure. Here, the etiology of microvascular dysfunction, it is related mainly for isolated microvascular dysfunction. And the most important line of treatment here, if there is any possibility of spasm, you can give calcium channel blocker, and this is the drug of choice. And don't forget to do acetylcholine testing. If there is acetylcholine showed a spasm at the level of the epicardial or intramyocardial, I mean microvascular dysfunction, because the acetylcholine can cause a spasm in the microvasculature like in the epicardial vessel by different doses. So if there is documented spasm, the first line treatment here, the calcium channel blocker, ACE inhibitor, or ERBs. But if there is no spasm induced by acetylcholine and mainly elevated IMR, the drug of choice here, beta blocker, nicorandil, ranolazine, and trimethidine. And you can combine according to the patient situation. And this is what was documented in CORE-MICA trial. The patient who showed only isolated microvascular dysfunction without spasm, they will get benefit from escalation of anti-ischemic medication, and it will show significant improvement of angina score and the quality of life.
Thank you. Dr. Khalid, I have a question for you. Do you hear me?
Yes, I hear you.
If you have a patient with 2 CTO, what is the criteria for opening which vessel, say LAD and RCA, and he is living in some collaterals from the big, huge dominant left system? Patient is symptomatic. How are you going to stratify him? And what is your approach? And what is your advice for the young people to deal with such problem?
So if we have a LAD CTO, RCA CTO, I send him to cabbage first. So if he's not refused, if the cabbage is not an option for these patients, so usually I'm start with the LAD. LAD for the patient, it's the most important. I'm not starting according to the easier one, so I'm not starting with the easy one, but I start with the LAD as usual. If I have a good enough collaterals who can do for me enough for the patient. But if we have a 2 CTO with poor LV function, so we have to have a assist device before to start. So if we have a single remaining artery, and I will use one of these artery as a collaterals, because if you say we have a LAD, you have a RCA, it means he's living in circumflex. And if he's living in circumflex and something happened when you are working, patient will not come back. So you have to do this patient with assist device, especially on umbrella, before to start. And this all the American school now, they start to do all this patient with single remaining vessel with assist device before to start. If you have assist device, then it's easy to start with the one who will give you the good supply for the other one. Like if you have the LAD and then patient will be relieved to the other. But if we have circumflex CTO and the RCA CTO, I will start with the dominant one. The dominant one, if the dominant one is circumflex, I will start. But if I have the LAD and the RCA, I will put an assist device, stabilize the patient, and then do CTO to the other. If we are in a country, there is no assist device because we are talking to Egyptian, and there is no assist device there. No aortic balloon pump is not, it will not do anything. So there is no umbrella in Egypt, or there is, but very, very, very expensive. So patient cannot affect. So I will start with the one who can be treated safely. So if the LAD can only be treated by retrograde, very long segment, difficult, complex, calcified, and the RCA short segment, easier, will not take a lot of time. So I will start with RCA, leave the patient for 1-2 months, have a good collaterals to the LAD, and then do LAD.
Good. Dr. Abdul Maqsood, maybe the last question because of the time. Do
Yes.
you do IMR in every patient with normal epicardial coronary arteries?
Yeah,
Or do you recommend that?
it's a very good question. Actually, I asked the Abbott company for the guide wire RadiX or RX wire, because we are using now the regular wire, which is having the pressure sensor. For the meantime, last month I asked Abbott company to give us the unique wire to measure the FFR, CFR, and IMR. And now they did the paperwork to the Saudi FDA to get approval to get this wire inside the kingdom. For sure, once we have the wire available in Jeddah, we will use it. And as you know, Dr. Muhammad, we are confronted a lot of problem with the insurance company. If the patient came by angina and the positive stress modality, and we reported the angiography normal, they will reject and they will send us your rate of normal angiography, it's 20% or 30%, and this is not accepted for us. So for sure, if we have this wire, we will do it for any patient who have true angina, documented ischemia. So we will do IFR. For a STEMI patient, for sure, from the data of STEMI, because it showed significant reduction of mortality, post-revascularization, we will do IMR to check the microvasculature. If normal IMR, it will predict a good recovery of the left ventricular function, and it will improve mortality as show the multi-center study, the last one. If high IMR, we will give intracoronary TBA immediately after the procedure if the IMR more than 25. So for sure, if we have the wire, we will use it routine post STEMI revascularization to check the group of patients who have high IMR, and you can give immediately post revascularization by primary PCI to give intracoronary lytic therapy. For chronic stable angina patient, we mentioned about 20% of this group of patients, they have a normal or non-obstructive coronary artery. More than 50% of this patient, they have microvascular dysfunction. So we will do also for this group. So we have 20% of patients with angina with non-obstructive coronary artery disease, we will do the IMR. And the post-STEMI, we will do IMR. And don't forget, please, the diffuse pattern of diffuse atherosclerotic lesions. If you will do FFR, CFR, and IMR, you can also detect the diffuse atherosclerotic changes by the classic gradual delineation of the pressure curve, like the draft, and no focal step. If there is focal step up of the pressure, it will indicate focal lesion in this group of patients. So I think the future to use the new technology RX wire, RadiX wire, to check all the physiologic indices, which is FFR, CFR, and IMR.
One wire.
Yes, but by one wire. And it's a
Professor
it's a 5 minute
yes.
job.
Do we have more time?
Actually,
Or that's it.
okay, no, we have 2 minutes to finish, actually. And if you let me conclude, because I have had a wealth of information today from Abdul Masood and Khalid, and actually it was very nice. We enjoyed it. Just to summarize or to remind ourselves, we were talking about two different categories of patients, one with thrombus-containing lesion or microcirculation. We can call it acute total occlusion and chronic total occlusion. Acute total occlusion and chronic total occlusion, they shared one important point, how important the myocardium is. And the aim in both situations and in both categories is to preserve myocardial contractility and to preserve the myocardium to avoid the complications of ischemic heart disease later on. But they differ in everything later on. What are the equipment to use? What are the precautions? What type of complications? And they differ in everything, but they shared acute total occlusion and chronic total occlusion. The aim is the myocardium. I thought from Dr. Khalid tonight, which patient should I subject him to CTO intervention? Viability. This is very important point, and the most important point I have heard tonight is viability that Dr. Khalid mentioned. There is no need at all to try CTO in non-viable myocardium. Which patient to subject to CTO? What are the possible complications? What are the equipments that should be available? And what are how to guard against the complications, and a lot of information. Actually, I enjoyed it very much. And I'm very happy tonight having you all, the three of you. And it was a nice night with you, Mohammed Belghaiz. Looking forward to seeing you in the future. Khalid, this is not the last time, please. And Dr. Belghaiz, next time we will be waiting for your talks, inshallah. You can conclude now if you wish.
I think all of us, we enjoyed it, and I would like to thank my friends, the speakers, and the participants. Thank you very much for this nice night and for the invitation. Thank you.
Okay, see you. Dr. Khalid, would you like to say something?
Thank you. Khalid? Thank you, Dr. Sameh, for this very nice night and nice invitation. I enjoyed also all the lecture with Dr. Abdul Masood and Dr. Muhammad as my dear friend, and your lecture as well, Dr. Sameh. Thank you for inviting me.
You are very good. Abdul Masood?
Well, as I mentioned, I'm really happy and enjoyed the meeting, and we learned so much from the presentation and from discussion. And really, I'm so happy to be in my home, Al-Azhar University, the School of Medicine. I started and continued my education in the cath lab and the cardiology department for the non-invasive and the invasive approach, and the long history with you, Dr. Sameh, and my professor in the department. Thank you so much for giving me the chance to join and to give this talk today. Thank you so much.
Thank you all, and looking forward to seeing you next time, inshallah. Goodbye.
Assalamu alaikum.
Assalamu alaikum.